Hey, how are you?
What's up, homie? How are you?
Good.
Good, great to see you.
Yeah, you too. What's new?
Nothing's new. Just trying to stay warm. It's a lot easier for you where you're at.
Yeah. Where are you?
Salt Lake City.
Oh yeah. Yeah.
Salt
Definitely
Lake
easier.
City. We have had such a weird snow year. We've had very little snow. The ski resorts have really been hurting. They've only gotten like just a few little inches. So I can't complain too much. But yeah, you're down there shoveling sunshine.
Yes, it's like 50 degrees today, so we're all out in our parkas, but it's much better than being buried in snow or my wife and my kids are up in Minneapolis right now, and so they're freezing their
Oh,
butts off.
geez. Yeah, I've heard it's really, really cold up there right now. And yeah, is it tomorrow? I think it's Friday. They're doing the Winter Classic, kind of down there by you. They're doing it in Florida this year. So
Oh,
outside ice hockey game, and they brought up the weather and said it was going to be about 50 degrees. So that's not like super warm.
no, it's not. And it's probably comfortable for a hockey, you know,
Yeah.
like outdoor hockey like that. That'd be actually
Yeah,
fun to go
probably
to.
perfect. Yeah,
Yeah.
exactly. Well, cool, man. Well, thanks for doing this. Like I told you via email, the first one was great. We had a lot of really good responses, and so yeah, happy to have you on again. I really appreciate it. Is there anything you want to make absolutely sure that we cover in this conversation today, or just keep everything in your wheelhouse?
I think so. That's fine. I mean, I don't have anything in particular on my mind or
There,
agenda.
it was an older podcast. So I don't know where you were with this, but there was an older podcast I listened to. Maybe you did with Dr. Baker, where you were
Hmm.
mentioning some kind of a program that you were doing. I don't know if that ever got started or whatever, but
Life kind of got in the way with me, and what I realized was there were similar things out there already,
oh,
and especially like for example, Dr. Baker's stuff, right? With Rivero, there's a lot of blueprints like that I found that I was reinventing the wheel for no reason or
got it.
thinking about doing that, and so I kind of backed off of that because I just didn't think it was needed. It's kind of like when you talk about this stuff, like having like cookbooks and stuff, like there's a zillion of those things out there.
There are. Yeah,
And so I just didn't feel like at the end of the day that it was going to be, something that was different enough from what was out there already.
got it. Got it. If you ever did decide to do that, is there a particular format you think you would do, like a YouTube channel or podcast or some type of program or whatever?
I don't
Not
know.
necessarily.
I've gone back and forth about how to do that. I mean, people do like these, kind of like courses or yeah, I mean, people do YouTube all the time. Um, Kind of like I said, there's a lot of it already out there that's really good. And so part
Yeah,
of what I think is, if I point people in the right direction,
yeah.
that's probably enough. And then doing things like this or um, whatever I can otherwise to spread the message is probably enough.
Cool. Yeah, that's cool. Yeah, it's a lot of work. You would be very good at it. You're good on camera and you're a good podcast guest, so you'd be good at it. But yeah, it's a ton of work and debatable whether you get the return out of it for as much work as it is. So anyway.
Right. For sure.
Awesome. Okay. Well, let's see. We'll release this episode in a few weeks. Just like last time, I'll send you everything. I know you're not hardly ever on social media, but if there's ever anything you want to do with it, you can. You don't need to wait for the release of the episode. There's no
Awesome.
obligation, even if it's just like sharing it with your friends and family. You can do that anytime. And then, yeah, music will play on my end for about 30 seconds. I'll get you introduced and I meet you. We can just go from there.
Sounds good.
Go. Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to reintroduce to you now. Dr. Christopher Netzel is a returning guest on our show. Be sure to check out his appearance in episode 644 of Boundless Body Radio. Dr. Christopher Netzel is board certified in pain medicine and anesthesiology, practicing at Coastal Health Specialty Care in Jacksonville, Florida. His medical residency in anesthesiology was completed at University of Wisconsin Hospitals and Clinics in Madison. Dr. Netzel is a member of a number of medical associations, including the North American Neuromodulation Society, American Society of Anesthesiologists, and the Wisconsin Medical Society. Dr. Netzel utilizes whole food, low carbohydrate, healthy fat, and ketogenic diets as a component of a multidisciplinary approach to address metabolic syndrome within the context of chronic pain. Through this approach, improvements in many types of pain have been observed, likely due to weight control, decreased inflammation, enhanced glycemic control, and potentially improved neuronal function. Furthermore, Dr. Netzel has successfully assisted patients in reducing or ceasing their usage of diabetic and hypertensive medications, achieving better sleep quality, experiencing reduced heartburn, and increasing overall enhanced well-being. Dr. Christopher Netzel, what an absolute honor it is to welcome you back to Boundless Body Radio.
Thank you for having me. I really appreciate it.
Yeah, it's an honor to host you. We had great feedback on our first episode. We had a lot of people comment on YouTube and had great things to say. So it's great to have you back on the show and kind of get an update on everything that's going on. We're recording this in the time of year where I don't think you're missing Wisconsin too much. You're enjoying Florida this time of year, I would imagine.
That's correct. I don't miss getting up at 4 a.m. and shoveling the snow.
Man, yeah, I'm sure you don't. And you told me it's actually about 50 degrees there right now, so it's not even that warm. It's always funny to go to a warm climate when you're from a cold climate and you're the one in shorts and a tank top and everybody else is all bundled up.
That was almost the worst part about living in Wisconsin when I did was, in the spring and March, it sort of fooled you into thinking that 30 degrees was warm.
Yeah.
And everybody's out there in shorts and tank tops and flip-flops.
Yep, exactly. Yeah, one of my clients even just today was saying it was going to warm up to 35 degrees, and I pointed out to her how quickly our idea of what warm is depending on where we live and what season it is. So I'm glad you're still enjoying it down there. I wanted to go into the topic we went into last time, talking about pain management, things you've learned, maybe some updates if there's any new research that's come out. We didn't get a lot of your own personal story in our last conversation, and we'll talk about your personal health, but I'm curious how you decided to get interested in the medical field and in this specific realm.
This specifically, follows the pattern of so many of us in this space, in the sort of the low carb or sort of ketogenic space, which is their own sort of medical struggles. I came out of medical residency and fellowship not in very good health. You spend those years working sometimes 80 to 100 hours in the hospital. You're eating whatever you can scrounge up, and when you're there, you're not really doing much physical activity. Your sleep is messed up. It's not a great recipe for health overall. And so I came out of my residency and fellowship, I don't know, probably 40 to 50 pounds overweight. I was probably 230 and change at the time. And it wasn't like a muscular 230. It was, it was years of not taking care of myself. I had joint pain. I wasn't sleeping well. I had heartburn. I had the whole kind of the recipe for having overt metabolic syndrome. I was, arguably there from a weight perspective already. I didn't have blood pressure issues or diabetes yet, but I was well on my way. And so I don't remember which book it was that I picked up first. It might have been one of Gary Taubes's books. It might have been Dr. Fung's books. I can't remember, but I started, reading some of their things and started rethinking the way I've thought about nutrition over the last, over my career. And I implemented it in my own situation slowly. I mean, everybody goes through a journey with that. You start with a lot of, I guess, for lack of a better term, keto friendly or healthy treats, so to speak, and then you kind of transition to, I guess, real food. But in that process, I lost 35 to 40 pounds without touching the gym. I mean, I didn't do anything other than just change the way I was eating in terms of better quality, low carb-ish, and real food, and a little bit of intermittent fasting, nothing crazy. And I said, there's something to this. And in the process, my joints started to feel better. The heartburn went away. There was a nightly thing I was dealing with, and all of a sudden it was hardly ever. And so I just continue to go down the rabbit hole of kind of educating myself on the science behind some of that. During that process, I went through the CME to become obesity medicine certified. I went through the trainings through the Society of Metabolic Health Practitioners in low carb nutrition. And simultaneously to all this, I was starting my own practice. Or not my own practice. I was starting out as an attending at a practice and trying to get my feet under me. And it was, 90% of my patients that I was seeing also had some of these issues, whether it was the weight issues or the diabetes, high blood pressure, you name it. And so many of them were not getting any real advice. They would go to a doctor and maybe they needed a knee surgery or a back surgery, and they were, their BMI was too high to do it. So they'd say, lose some weight, let me know when you do, and see you later. With no guidance, no nothing about how to do that. And I thought that was, a disservice to those people. And so I started to gradually branch out and give them some of the recommendations that I had seen work, not only in myself, but, that were supported by the evidence. And lo and behold, a lot of those people came back and they were going in the right direction. And so it was a bit of a simultaneous process of my own journey as well as my professional journey, starting to use this more clinically.
Yeah, for sure. I don't want to miss this, and it's so consistent. I just find it absolutely striking. The number that you just said, 90%, that is no exaggeration. 90% is the number you put it at. So for 10 people, 9 of them have metabolic syndrome of some kind, obviously.
In my mind, yeah. I mean, whether or not they know it is a different story. But, the way we measure or sort of pick up metabolic syndrome is really late in the process. I mean, by the time your blood sugar elevates or your A1C goes up, you've had underlying insulin resistance for years, potentially longer than that, potentially decades. And so, if we were better about measuring fasting insulin levels, or even doing glucose challenges with insulin measurements during that time, we'd pick this up a lot faster. Pretty much anybody with hypertension is in my mind metabolic syndrome until proven otherwise, because it's just the most common reason for it outside of primary kidney problems or to a degree smoking. And so, yeah, I mean, I saw 15 to 16 people today, and just about every one of them fit the criteria enough in my mind. And so, yeah, it's the most common thing that we see on a regular basis.
Yeah, I maybe told you this last time, but since our first interview, I've been really diligent in asking this question to people that are specifically in emergency care situations and asking them that same thing. Like, what percentage of cases are you dealing with that are things that I would think of people would go to the emergency room, like a broken leg or, they got clobbered on their bike or whatever. And it's the same. It's like 10% is that. And the other 90%, even in emergency care, is chronic care. It's terrible.
Right.
Wow.
Yeah, unfortunately, the too much of what you see in the ERs is really, like you said, chronic care management. It's part of the reason I didn't do emergency medicine as a specialty. In addition to, I didn't like the idea of having shift work like that. Where you're working 7 a.m. to 7 p.m. one day, and then the next day you're working 10 or 10 p.m. to whatever it is, 10 a.m. or you're out in these weird oddball shifts and your sleep is kind of all over the place. And it's fun to do that while you're in your 20s. Not so much when you're in your 50s, in my mind.
Yeah, I've got a few friends who do that, and it's pretty rough on them as far as the lifestyle goes. It's not a lot of sleep, and yeah, it can be really up and down. Okay, so what did draw you into pain management as the course that you were going to pursue?
So when I started medical school, I didn't know what I wanted to do, but for a while, I thought I wanted to do primary care. I slowly kind of realized that the reality of primary care nowadays is not logistically what I wanted to do. It's you really have to. You're almost tied to what the insurances want you to do and the guidelines and all this stuff, and I wasn't interested in doing that. So I kind of slid into anesthesiology because I like the procedural element of it. There's sort of pros and cons to it. When you're working, you're there, you're doing things, and then when you're home, you're done. You're not tied to anything, and so there's a certain satisfaction or sort of advantage to that. But then as I got into anesthesiology residency, you kind of have to start making a decision. Do you want to subspecialize or do you want to become a general anesthesiologist? And my perspective has always been I want to set myself apart in some way. And as I went through the possible specialties, pain management came up, and it was so similar to the things that I liked about anesthesia, and I didn't have the things that I didn't like. Um, anesthesia is sort of like emergency medicine. You kind of are tied to the hospital to a degree. You're on call. You've got kind of funny hours. You're there until the work's done. In terms of whenever the surgeries are done, you might be there on holidays, on the weekends. And I realized the things that I liked about anesthesia, the procedural elements, I could do that in pain management, see people on a longer term basis, meaning not just during their surgery, but more longitudinally, um, and work business hours. I could work 8 to 5, have a family life, have halfway decent sleep, all of those things. And so the drawbacks to doing it are really, you kind of deal with the stuff that comes along with having a clinic, which, there's no perfect situation, but that's kind of what drew me to that. Um, and then as a segue, again, it sort of lent itself to me starting to improve my own health. And then as an extension of that, being able to do it with my patients from a lifestyle perspective. And I got to tell you, the people that I talk about this with in the clinic sometimes are the most appreciative of that, meaning they're not used to getting that kind of discussion with most of their other healthcare providers most of the time.
Yeah. Wow. So you're talking about your patients, not like other coworkers.
Or both, honestly. Some of the coworkers will also, talk about it because they're dealing with it too.
Got it. Okay, that's cool. Tell us about the training to become specializing in pain management. Most people probably just think opiates or other medications, but what are you actually trained in?
So where I trained was at Rush University in Chicago for fellowship in pain management, and that was a very heavily interventional program. Meaning, it was sort of like being a surgery resident for a year, where we did a lot of procedural interventions. We were trained in how to do any and all the nerve blocks or sort of injection style procedures, as well as implantable devices or more advanced procedures, things like spinal cord stimulators or devices that deliver pain medication like narcotics to the spine itself, minimally invasive spine surgeries, peripheral nerve stimulation, all kinds of things. And really pain management as a field is going in that direction more and more. We are sort of inching closer to being, for lack of a better term, a surgical specialty than anything else. I don't try to confuse myself with being a surgeon, but we're closer to that than anything else. That's what I was doing this morning. And so, yes, narcotics are part of the equation. Medications in general are part of the equation. My general philosophy with the narcotics is I try to, outside of cancer situations or post-operative surgical pain, I try to be really judicious and stay away from the narcotics as much as possible. But I'll say that there's no black and white. You come in our office and you see some of these people who they don't have cancer, but they've had stem to stern back surgery from the bottom of their skull to the top of their crack. And there's only so much you can do for somebody like that. And so nothing is all or nothing here. My job from a narcotic perspective is to be stewards of it, meaning, use it as appropriately as I can while making sure it's safe, and that we're not doing it without thought. And then I of course, I try to maximize all the non-narcotic therapies as much as possible, whether that's medications, whether that's physical therapy, whether that's some of the procedures I do, whether that's nutrition, right? That's just another wheel or spoke of the wheel, I should say, of what we can do. Acupuncture, chiropractic, any of these things that are maximize benefit while minimizing risk.
Got it. Okay. Have you seen that evolve quite a bit as far as the medications go as you've been practicing in your career?
Yeah, I mean, 10 to 20 years ago, the narcotic sort of landscape was a lot more loose. I wasn't, practicing then, but we're sort of still picking up the pieces from that. If I'm being honest, I think that the pendulum for a minute there and maybe currently still has swung too much in the direction of avoiding narcotics. I am the first one to be very, very cautious with these, but we're in situations now where because of insurance pressures or pharmacy pressures or other things where we're almost not giving it to people who probably need it. And so I think that I'm hoping that we're coming back to a bit of a middle ground there where we use it judiciously and appropriately, but not for every patient or even in the majority of patients. I would say 9 out of 10 or 8 out of 10 of the patients that I see as a new patient, I don't initiate any kind of narcotic therapy ever. It's the folks again that have had a ton of things happen to them, or the cancer circumstances, or the post-operative pain, that I really try to stick to. A lot of patients come to me already taking the narcotics, and so I used to be very heavy-handed about weaning them. I used to say, we're going to get rid of it, no questions asked. Here's the schedule for how we're going to wean it down slowly over time. That might have been a little heavy-handed. Now what I do is I just tell them, look, the goal is to come down on it as much as we can. We're never going to go up on it unless something happens, surgery or some event. And we're going to use all these other tools that we can to sort of facilitate that
Yeah.
as much as possible.
That's well explained. I can't say that I'm too surprised that the pendulum swung so hard back in the other direction with all the negative publicity that those medications got for so long. I told you last time my mom had to deal with cancer, and like she was on Oxycontin, and I believe she probably needed the Oxycontin. She went through a lot of pain. So hopefully that does kind of come around to find that new middle ground, like you mentioned. Another thing I wanted to ask you about, since you brought it up, is insurance. How challenging is it to work with insurances on your end as the providing, the doctor providing care?
Incredibly. We are in a landscape right now where the insurance carriers they stand to gain the most from doing as little for our patients as possible. And so their strategy is to put up as many roadblocks as humanly possible to make sure that things don't get approved. And so I don't want to get too in the weeds politically necessarily, but I mean, there are insurance plans out there that I can't do anything for these patients. They would, other than pills, they would much rather me slap them on some narcotics and send them out the door and see them every month, forever and ever. Amen. That is the path of least resistance. There are insurance plans. This just happened today where they will, quote, approve something or not require authorization for something, but the reimbursement for that procedure, even if they approve it, is zero, right? So authorization does not necessarily guarantee payment. They'll tell you that right away, but we're not doing things willy-nilly. We're not doing things without some justification. And it's a shame because we can't do what we think is appropriate for these patients. The cost of the procedures, it continues to get pushed back onto the patient themselves rather than the insurance companies. And the cost of doing business on the physician or the medical practice side only continues to go up for a number of reasons. And so, people sometimes get this impression that you go into medicine sort of for the money in part. And yeah, you make a good living as a physician, but it's not the golden age of medicine anymore, where you can do what you think is appropriate for the patient. There's so many layers of barriers. I mean, I got a peer-to-peer phone call, which is the insurance company has a physician on the other end that will call and talk through cases to either approve or deny it based on the criteria. And I got a phone call on Christmas Eve at 7 o'clock. And the reason they did that, in my suspicion, is if I miss the phone call, if I don't pick that phone up, I miss the window to appeal that case, and then it's over. So they're counting on me not picking up the phone on Christmas Eve to not have to approve this procedure.
That's savage.
Yeah, that's the kind of stuff we're dealing with.
That's great. I can't imagine. I mean, you got a sense of it there in your reply, but to be the doctor who was trained, who has the experience, who has the people in front of you, there's so much subtle nuance that is not just like, oh, this person's presenting with this, and so follow the flow chart and they have to have this done. Like you have a judgment, and rightfully so, because you know these people and you've seen these situations, and you still don't have the option sometimes of doing what you think is going to be best for people. That would drive me crazy.
Yeah, it's like I say, there's so many layers to this, when it comes down to, the structure of our healthcare system, but to get things done, if I have a patient who's got a fracture in their back, a compression fracture, some of these insurances will make me do 8 weeks of physical therapy. They need to see the endocrinologist, which takes months. Those people are booked out at least 3 months. Um, they've got to fail like three other medication options. You got to get an MRI, you got to get a CT scan, you got to do all these things. Meanwhile, so you're looking at 3, 4, 5 months of workup sometimes. And meanwhile, this 85-year-old little lady is in a ton of pain.
Wow.
Whereas if I find that fracture and the imaging looks reasonable, I can put some cement in that fracture. It's called a kyphoplasty, and I can take care of that in a week. Um,
Wow.
but that's not the way it works.
Wow.
So, and I suppose if you think about it, that's another reason that I work so hard on this, meaning the nutrition part is, that doesn't require authorization. It doesn't require a pill or an injection or surgery. And I talk to people about it in terms of probability, meaning it just raises your probability of feeling as best you can. Same thing with smoking, right? Or alcohol for that matter.
Yeah. Okay. Awesome. I do want to talk about the nutrition stuff. I did have one more question. Who
Mhm.
who are your patients? Of the 16 people you saw today, you mentioned there's a common thread as far as like metabolic poor health. Other than that, like what are some other commonalities you see, or did you see 16 completely different cases today?
Very different cases. I mean, I would say the biggest thing that we see is low back pain. I mean, that's the most common problem. And then after that, neck pain. But we see, people with nerve pain conditions. A complex regional pain syndrome is something that where I trained, they specialized in particular. And so that's a nerve pain condition that follows surgery and or an injury of some sort where there's a hypersensitivity in the nervous system, typically in the extremities or the hands and feet. I will see migraine patients. I do a decent amount of migraine work. In that regard, the neurologists and I have some overlap. Um, People who have had back surgery or neck surgery in the past and still have pain syndromes. I'll see joint pain, hip, knee, shoulder. And so there's really not much that we don't see. It just kind of depends on the day. And it's kind of streaky. I'll have days where I see, you know, 15 neck pain patients in a row or something like that. But it's um, on average, back pain is the biggest one, and it's a range of ages.
I was going to
We
ask.
do we do a little bit of personal injury work too. So when people have car accidents or some sort of injury, we see those folks, and so those tend to be a little on the younger side, but not always. And so we'll see people with cancer, we'll see people with sickle cell disease or other chronic conditions that are painful. So a little bit of everything.
Yeah, got it. And are these generally people that will be seeing you for the rest of their lives?
Forever's a long time. The ones that are on oral opiate therapy, the rules in this state at least dictate that we have to see them every month. Um, so probably, but I tell all my patients I'd like nothing better than to put myself out of business, if I could. And so um, like I say, forever's a long time, but yeah, most of them are going to be people that we see with some regularity for the
Got
foreseeable
it.
future.
Got it. Okay. And I know how tricky lower back pain is in particular, and this is a very generalized question. And so you could see 100 cases of low back pain, and there might be 100 different causes. You know what I mean? Like it's pretty tricky as far as that goes. But in general, besides changing the diet, what things would you like to see with most of your patients as far as the back pain goes? Um, Walking more, resistance training, not sitting as much. Like, are there generalized things that could help most people as far as the back pain goes?
I think there's a couple of things. I mean, first of all, my patient population struggles with physical activity because it hurts. And so it depends on the patient. Some of them, if I've got somebody in their 30s or 40s that's got, a non-traumatic low back pain, like they didn't have an injury, they didn't have any surgery in the past. It's mostly joint pain and muscle dysfunction, maybe some disc issues. Yes, we can coax them into more activity. Um, and I typically start with the physical therapy first, and then sort of expand from there. Meaning, it's not feasible for me to tell my patients with back pain to get out and do a ton of walking, even or resistance training right away because it's going to hurt. They're going to get discouraged. So I start with the therapy, and then do that at home on a regular basis, and then hopefully over time we're able to branch that out. That's part of the reason I work with the nutrition element, though, because I think that a lot of these people coming from what the standard American sort of diet, part of the reason they're having so much pain is they have a lot of inflammation. They're generally have weight issues, and so if we can get those going in the right direction, they might feel like they can do more physical activity. It might, as opposed to white knuckling it through a bunch of trying to go to the gym or something. You know, I try to get the basics right, meaning like if you smoke, knock it off, right? We have to get rid of that. If you're coming to see a doctor about stuff, whether it's me or a cardiologist or your primary and you got health conditions, you got no business drinking alcohol, period. It's a toxin. And so we can't, you know, hamstring your body by putting things that are clearly toxins in your body. And then, sort of as a segue to that, then the nutrition part comes in. Trying to get halfway decent sleep. I've been down a rabbit hole recently with circadian biology that I think is really fascinating. And I think there's a lot more to that we've given credit for. And that I think that we haven't scratched the surface of what we understand with that. But sleep is a big deal. Everything, if you get bad sleep, everything else sort of suffers. And then, at the bottom of that pile tends to be the activity part of things. If we get everything else right, my hope is that they can feel well enough to go out and do some activity.
Yeah, got it. Okay, awesome. As you were learning about nutrition for yourself, applying it to yourself, thinking like, what was the thinking like? Were you thinking like, okay, this is really helping me out. I feel better. I lost all this weight. I noticed that my patients need to lose weight. This diet would help them for the weight loss. Or was it occurring to you really early on that this diet really could address pain? Because I think that's really surprising to a lot of people.
It was sort of, it wasn't right away that I recognized that. I didn't think that right away. It was more as it happened to me, as it happened to some of my patients or my coworkers. I had a woman I worked with who was on the younger side. She was a heavier person. She had had a back surgery in the past, and by the end of the shift at work, she was hobbling around because her knees and her ankles were killing her and her hips. I got her kind of going in this direction with respect to nutrition, the way I talk about it, and even before she lost 5 pounds, it wasn't much. It was only a few pounds that she had really lost, but she didn't have that joint issue anymore, and so it was a joint pain improvement that was independent of weight changes, and that's what got me thinking about this. Like, wait a minute, there's something else going on here because I had another woman who she was very she was thin. She was in good shape, relatively speaking, but she was eating not the best. She was convinced she was going to need a hip replacement, and we got her eating this way. And she came back like 3 or 4 months later. She's like, my hip doesn't hurt anymore, right? And it wasn't that she lost weight; she was already thin to begin with. But that mirrors what you see from the orthopedic folks, Dr. Fetke, Dr. Baker. Some of these guys that have said these folks that thought they might need a knee replacement don't need it anymore. And so it was a little bit of that. It was me trying to give these patients a direction, as opposed to eat less and move more. Because again, like I just said, they can't move more. Not really. Not enough to move the needle on weight loss in most cases. And when you look at the evidence for physical activity for weight loss, it's really not very good. Like weight management just by purely moving more doesn't wind up panning out. Or you've got to be really you'd be so dedicated to it that it's not feasible
Yeah.
for my patients. So kind of all those things together. And then the more I looked into it, if you think about like a ketogenic approach, which I don't think is mandatory, like as like a strict, like you have to be in ketosis all the time, right? Like I don't like being dogmatic about that. But if you look at what that did for epilepsy patients, and still does for epilepsy patients, um, most of the nerve pain medicines or migraine medications that we use are seizure medications. And so you have an intervention, a nutritional intervention that treats seizures and does so very effectively. And then you're using seizure medications to treat nerve pain. So why wouldn't there be some benefit to nerve function in some fashion from a ketogenic approach? And that's what we see. And as an extension of that, you've got the work that Chris Palmer's done, Dr. Chris Palmer in psychiatry. And so, and as well as Dr. Georgia Ede, seeing benefits in terms of mood disorders, bipolar, schizophrenia, depression, you name it. And so, from a pain perspective, when it comes to that, mood and pain are so intertwined, it's hard to tease them apart. And when one improves or worsens, the other one tends to follow.
Interesting. I remember hearing about a study that was done. I want to say it was done in Australia, a very small study. It was a pilot study, 20-ish people. I'll probably botch all the details of this anyway, but what they did is they it was related to pain management. They had two different groups, one that was like full on ketogenic. They taught people how to eat a true ketogenic diet and validate it with blood and measuring and that kind of thing. And the other group, as the control, they basically just gave them, I believe it's called the Nova list, which is all the like ultra processed foods, and just said like, hey, choose your food from the first two groups or the first three groups or something. Basically just eliminate a lot of the ultra processed food, but not necessarily to the level of ketogenic where they're eating a very low carbohydrate diet. And I thought it was interesting because both groups during the study saw improvements of pain. It's just that the people in the ketogenic diet saw more improvements and they lost weight and this happened and that happened. Like there was like more things that happened. So they did get better results, but everybody got better results just by, cutting out the ultra processed crap, which I think is really interesting. And you've dabbled around this in this conversation already as far as like the mechanisms, why it is that we think this is. And I love hearing you talk about this. So I think you've gotten it down to like 4 or 5 different mechanisms of why we think this diet might be helpful for pain. Could you explain some of those to us?
Yeah, I think the most obvious or the one that everybody thinks about is the weight part of things. And I kind of get that one out of the way because it's the most, obvious. We know from the orthopedic literature that every pound of weight, one way or the other, is about 4 to 5 pounds of force on the knees and hips, for example. And so, if you lose a pound of weight, you tend to, your knees and your hips are going to see 4 to 5 pounds less strain. And that adds up pretty quickly. So, how that relates to the spine, I'm not 100% sure. They haven't, to my knowledge, I haven't seen any studies about that specifically, but it has to be, I would imagine that it's something somewhat similar. So that's one thing. But, I'm really careful about this, and I really like to make sure that I tell people it's not primarily about weight. Weight is a symptom. And so I don't want to say, hey, your back pain hurts because you're fat, right? That's a great way to alienate patients. And I don't do that. What I say is I want to get you healthier in a way that your weight goes in the right direction, sort of as a byproduct of what we're doing. The other part that's a big one is inflammation. I think that, if you look at inflammatory markers in metabolic syndrome, there's a significant association with elevations in high sensitive CRP and sort of subclinical almost inflammation markers. Gout, for example, kind of goes along with this stuff a lot of times, which is an inflammatory condition. And so, and what you'll see is when people go from a standard American diet to a more ketogenic approach, what's the first thing they do? They lose a ton of water weight. And a lot of that is sort of not only edema or swelling, but also just inflammation kind of lowering. And I think it explains the mechanism for some of these patients that we've seen with joint improvements without weight changes, right? And it's not really a nerve pain problem. It's an arthritic or inflammatory joint issue. And so that's a number two. The nerve pain thing is the third one, where we're using a seizure treatment, and a lot of the nerve pain medicines that we use are seizure medications. And we see this where we see elevations in inhibitory neurotransmitter activity, not only in the brain but in the spinal cord. GABA activity goes up. Glutamate activity tends to go down in ketogenic nutrition, and so I think that's a very simplistic way to look at it, but I think that it just illustrates the point that you get less hyperexcitability or less activation of the nervous system. And in chronic pain, most syndromes are one part inflammation, one part nerve hypersensitivity. We call that central sensitization or peripheral sensitization, where the nervous system becomes overactive, telling your brain you're having pain either more often or to a degree that is out of proportion to the actual insult or injury. And then the fourth one is that mood part of things, right? So many of our patients are on antidepressants, or they've got anxiety or whatever, mood consideration. And so if we can calm that, quiet that with a nutrition strategy that doesn't involve pills, you're going to see improvements in that. And so Dr. Georgia Eid has been doing this for a long time. She's been able to take patients, severe schizophrenic patients or bipolar patients, major depressive patients, and cut their meds in half sometimes, or even more, by putting them on a sort of animal-based ketogenic approach. And then again, Dr. Chris Palmer has been doing very similar things and publishing very similar benefits. So there's precedent for that, and they're finally starting to get around to, I guess, recognizing it in the sphere of psychiatry. When you look at these studies that are done on most of the antidepressants out there, they're not that great, meaning you might see a 70% responder rate to a certain antidepressant, but the placebo response rate is like 60%. And so the difference in terms of placebo versus drug response is not very much. And I don't think that the model of, your brain just doesn't have enough neurotransmitters, I don't think is a sufficient model to explain what's going on. Whereas if you look at an insulin resistant brain, the brain has to utilize insulin in order to burn glucose and use it appropriately. And so if you can't do that, your brain starts to freak out almost. It starts to malfunction. You get weird side effects or symptoms. And that could be brain fog and memory issues. It could be depression, anxiety, any number of things. And so, I think it makes sense that treating insulin resistance and metabolic syndrome, at the very least, can benefit that. I guess, and then the last one, which is, I hesitate to go too far into this one because I don't think we have a handle on it, which is the gut microbiome. There's something there, and we know there is, but if you ask me exactly what's going on, I'm just guessing. I think that the broad strokes here are, if we stop putting stuff in there that screws up the gut microbial composition, and you give it real food and whole foods that are not processed in any way, it's going to get better. And that extrapolates into a whole bunch of benefits, insulin resistance being one of them, weight being another one, mood. The biggest source of neurotransmitters in our body is our gut. And the biggest source of our immune system is our gut. And so if we can stop sort of poking the bear, we're going to feel better, period. So that's kind of the way I talk about that.
Amazing stuff, man. Yeah, I absolutely love that. And what you're describing is this whole system of the way the body uses energy. It's not a fad. It is just a natural metabolic state that people should be able to slip into and out of depending on the foods that they eat and the energy that they need to burn. And it's not a fad. Like, all the things you're describing are all like upsides with very little downside. There's not a lot of compromise. Like, okay, get out the ultra processed food, that's going to help. And then all of a sudden you introduce more ketones, the things the body uses ketones for, even like you said, in the brain, like signaling. It looks more like a hormone than it even does, a piece of energy that the body can consume. It's amazing to learn about. And you have this limited amount of time to communicate that with somebody as you're seeing them. Are you finding that it's really difficult to kind of get somebody like super excited, or at the very least convinced that this isn't just another fad diet that you see on a magazine cover at the grocery store kind of a thing? Like, how are you able to kind of communicate that, and is it well received by people?
The way I approach it is I don't call it keto number one because, and I tell people that because, like you said, what do you see when you go to the grocery stores? You see a bunch of garbage that's labeled keto friendly that is just processed food, and you see it in the magazines and whatever. What I tell them is I tell them I want to try to get you eating the way our body and our species is built to eat, more or less. You don't. I tell them you don't feed a rabbit bacon, you don't feed a lion spinach, but we do it to ourselves all the time. We give ourselves things that our species never had or had for 100 or 200 years in its existence, over the last several million. Um, and so, I bring it down to, get rid of all the processed things, of course. I pretty much get rid of most of the grains. We've had grains in our diet for 5 to 10,000 years ish, something like that. That sounds like a long time, but on the scale of evolution, it's not. And I don't have a whole lot of examples in which grains are beneficial from that perspective. And then from there you get them eating mostly some version of red meat, eggs, seafood, fish, chicken, pork, leafy stuff, and dairy. Maybe some seasonal fruit depending on the person, but honestly, fruit is tricky because what we have today is so much bigger and sweeter and available all the time. And so I think that we've turned it into candy, and it's something that's continuous. Whereas 1,000 years ago it was seasonal; it came and went. And as you mentioned, I like what you said about we can come and go with ketosis, meaning I try really hard not to get bogged down in like you have to be in ketosis 24/7, right? This is not meant to be like that. We're just meant to kind of slide in and out of it with the changing sort of environmental inputs. And so I don't tell people that they need to get meters and tests and all this stuff necessarily because they just get kind of neurotic about it. And it's overwhelming for some of these people, especially if they're coming from not doing anything at all. But what you asked about getting them excited about it, the thing that gets them most excited about it is it doesn't involve pills, and that if they're on blood pressure or diabetes medications or their weight is a problem, this is a way to help with those things and get them off of drugs, and that is usually the biggest motivator. Um, they like the idea of the potential of getting off of 3, 4, 5, 6 medications.
Yeah, yeah. So that is extremely motivating. As you observe, you mentioned all the nonsense that you have to put up with in dealing with insurance companies and all the things that are not as glamorous as most people would imagine a doctor's life to be. The lot that you have to deal with, but also having this knowledge, sharing this knowledge, seeing some success stories, that must have completely transformed your own ability to appreciate and love your job. Like your job satisfaction must be way higher, especially as you look around in the industry at other people trying to do this without knowing anything about nutrition. Is that something you've observed?
Absolutely. Nobody, you go to these conferences for pain and nobody's talking about anything nutrition oriented. It's all about the newest, fanciest procedure that's out there, or to a degree, some of the medications and all that. And you're right. Some of these patients that I've seen, have massive improvements are some of the most rewarding people that I've talked to. Ironically, I don't see them much anymore, right? Because they're doing fine or they're doing better than they were, so I don't see them as often. But yeah, I mean, that's one of the biggest differences between doing anesthesia and pain management is, in anesthesia, you never get to see these people again. With this, you get to see them every now and then and follow along with them, and you can see some pretty big improvements. I think, I wish the system was set up in a way that it was easier for folks to do these things, to eat better and have more time to sleep and not have so much stress with money and their jobs and everything else that would facilitate this. But yes, it is one of the most rewarding things that I do, if not the most rewarding thing that I do in my job.
Yeah, that's amazing. It's so disappointing to hear about the conferences. Like, I don't go to medical conferences, obviously, but the only thing I can relate to is going to a low carb conference where you go, you see all your friends, nobody falls asleep in the afternoon, everybody's super energetic and friendly, and you're going over this amazing research. And it's just like the greatest weekend. It's so much fun to hear about other medical conferences out there where, they're not talking about this stuff, people are not accepting it. It's such a bummer because the contrast between the two, it sounds like night and day. But yeah, I'm so grateful that you'd want to come back on and share your story again and talk about where this is going. Hopefully, in the next few years, this starts to catch on a little bit more as more case studies are piling up and more research is being done. But I think it's pretty cool what you're doing on the ground and how you're striving to get this to the people that you're helping to see those actual results. Must be very, very rewarding. So, thank you again for coming on and taking time to be on our show today. Where would you like people to go to find you and connect with you in your work?
So I'm on Instagram. I don't use it a ton, but I'm on there. I'm a keto pain doc on Instagram, and I kind of use it sparingly. Me and Instagram or sort of social media as a sort of a double-edged sword, I guess, relationship. But that's where I'm at now.
Got it. Okay, awesome. We'll link that up in the show notes. It's funny that you did mention that. I know you're not on social media that often, but when I just pulled up your stuff, it looks really nice. Like the stuff you put on there is really good and clean and has really good information. But on just the very first page, I saw the little advertisement soundbite that we made for the first episode, and that was back in 2004, or I'm sorry, 2024. And so, yeah, it's not like you're posting all the time. That's still on the first page, but the information that's on there is really good.
Yeah, no, like I say, I go in streaks with social media. It's just I'm like an older millennial a little bit. I just haven't been able to assimilate it into my life as well as I think I probably should. But
Yeah.
maybe someday.
Maybe one day. Yeah, don't worry about it for now. Dr. Chris Netzel, thank you so very much for all the amazing work that you do, and thank you for taking time out of your very busy day to come on our show. We really appreciate you.
Absolutely. Thank you for having me.
Yeah, it was an honor. And this has been another episode of Boundless Body Radio. It was awesome.
Yeah, thank you. I appreciate it.
Thank you. Great job. You're a great guest.
Yeah, happy to do it. You do anything for New Year's tonight?
Sleeping in. Yeah,
Me
nothing.
too,
How about
man.
you?
No, dude, I'm gonna be in bed by 9. It's gonna be great.
That sounds wonderful. Yeah, that's a good day for sure. A steak, a
100%.
sauna, and in bed early.
That's right. I'm gonna go work out now, and we'll see where it takes me.
Awesome. Enjoy, man. Have a great day. Happy New Year. Thanks again for doing this.
Yes, sir. Thank you.
See you, brother. Take care. Bye bye.